First of all, I'd like to welcome everybody. Thank you for joining the Red Door community and the Leukemia and Lymphoma Society tonight. We have a blood cancer networking event, which we haven't done before, so this is new for all of us. We're very honored to have Dr. James of Memorial Sloan Kettering here with us tonight to present her topic, the emotional impact of watch and wait, fear of recurrence. I'm Eileen Polito. I'm the Associate Director for Program at the Red Door community, and I'm co-hosting this evening with Marie Macias, the Patient and Community Outreach Manager at the Leukemia and Lymphoma Society. Before Dr. James begins her presentation, I just wanted to provide you with a few slides, give you a little bit of a background on the Red Door community. The Red Door community is a nonprofit organization which provides free cancer support for anyone and everyone impacted by cancer. Our members and their families are living with cancer. They may be in treatment, they may be post-treatment, they may be caregiving, or they may be grieving the loss of a loved one. Our programs provide support groups, educational lectures, healthy lifestyle workshops, and social activities. At this time, all of our programs are virtual with the exception of social activities. Our mission is to bring knowledge, hope, and empowerment to every stage of a cancer experience. Although we have many support groups, we have our monthly blood cancer support group, which meets the fourth Thursday of the month. And the next time the group meets is going to be on Thursday, February 22nd. So just to mark your calendars for that. I do have a few housekeeping tips. I just wanted to remind everybody to mute your mics during the presentation. If you have any questions, you may add them to the group chat. And Dr. James will do a Q&A at the end. You can access your mics at that time. So now I will turn this over to Marie, and she can give you some background on the Leukemia and Lymphoma Society.
Hi. Before I start, I think I did see a question in the chat regarding if we were going to record this. So Eileen, I'm not sure if you want to record it, but if you want to.
It is being recorded.
Great.
Yes.
Great. Good evening, everyone. My name is Marie Macias, and as Eileen said, I am one of the patient and community outreach managers at the Leukemia and Lymphoma Society, and so I'm just going to go ahead and give you a quick overview of the resources that we offer. So as I said, I'm one of two patient and community outreach managers. I oversee Brooklyn, Staten Island, Queens, and Manhattan. So if you live in any of those 4 boroughs and you have any questions about the resources that I'm going to go over, my contact information is on the screen. The Leukemia and Lymphoma Society is the largest nonprofit dedicated to fighting against blood cancer, and we do this through a 3-pronged approach. Since our inception in 1949, we've invested over $1.6 billion into scientific research. We advocate at the state and national level, and what I say is, more important, we provide free education resources and information to patients impacted by a blood cancer. And all of our resources can be found on our website under the Patient and Caregivers tab. So the hub of all of our resources at LLS is the Information Resource Center, the IRC. They are open Monday through Friday from 9 a.m. to 9 p.m. Eastern. They are a team of highly trained oncology social workers and nurses that can help you navigate any part of your survivorship. I will say that most patients do connect with LLS because of the financial support that we offer. We currently have a patient aid program that is open and available to patients of any blood cancer diagnosis, and there is no income criteria. It is one-time $100, and we actually have a copay assistance program available for CLL, CML, lymphoma, and myeloma patients. There are eligibility requirements for the copay assistance, but if you have a blood cancer, Our inactive treatment, I highly recommend filling out that patient aid program application because it is one time and there, like I said, there is no income criteria, so everyone can qualify. At LS, we offer a plethora of support services, and on the screen, I think our most popular is our Patty Kaufman peer-to-peer first connection program. So if you are a patient or a caregiver and you want to be matched with a fellow survivor or caregiver who can understand the exact experience that you're going through, you can ask for a first connection request, and we do our best to match patients slash caregivers to our trained peer volunteers. And we do this based off of demographics or any shared experiences or similar characteristics. We also have very popular support groups very similar to this one. For education, we provide both in-person and virtual events. Upcoming is our Tri-State Blood Cancer Conference on Saturday, March 9th. It'll be at the Marriott Marquis in Times Square. It is our largest patient-centered education program. And like I said, the IRC is the hub of all of our resources. So if you have any questions, you can always reach out to me or you can scan that QR code. Thank you.
Excellent. Thank you, Marie. Okay, and now I'd like to introduce Dr. James. Thank you so much for coming to speak with us tonight.
For the start of this, we'll go through some slides that I've had prepared, but the chat should be open also for questions, but we'll definitely leave some time open at the end. Okay. And I'm just looking in the chat now. So my name is Monique James. I'm one of the psychiatrists at Memorial Sloan Kettering Cancer Center. I am an adult psychiatrist by training. I also have a specialty in bioethics and medical education. Here at MSK, I have both an outpatient clinic as well as see patients when they're hospitalized here at main campus. And so my clinic space is very kind of traditional psychiatric kind of office. And then in the hospital, you see a variety of patients who are there, whether they're there for treatment, surgery, transplant, these kinds of things. I work both with our fellowship pretty closely here. We have a psychiatric kind of consult fellowship, as well as with our nurse practitioners, residents and nurses and medical students as they come through. In my outpatient practice, we also see a lot of different kinds of patients with different kinds of cancers as well. I also have a specialty or a special interest in women's mental health. So a lot of my patients tend to be women as well, cisgendered women. And so our experiences here are quite varied, right? In the kind of Department of Psychiatry and Behavioral Sciences. I also see some caregivers sometime as well, or loved ones, as I like to call it as well, and also help with end of life as well here. So we wanted to talk about the emotional impact of a lot of, especially the kind of watch and wait and fear of recurrence in this next phase of the cancer world that a lot of us find ourselves in. So I will turn to share my screen now and share my slides. Again, I believe the chat is open and will continue to be open. And so please put in questions if you have, and then we'll also leave a time at the end where I'll stop sharing my screen and then we can see everyone again, okay? And just let me know if you all aren't seeing this.
Yes.
Okay, good. Okay, great. So again, welcome and thank you so much to the Red Door community and to the Leukemia and Lymphoma Society as well. I don't have any financial relationships to disclose. And so what I do like to do with all of the presentations that I have is to start by taking kind of a stock of how we're all doing. And so where are we going to go today? First, I do want to highlight the cancer world and our cancer populations. I also want to put a bit of a highlight on anxiety, as that is a lot of the, as that is a lot of the fear of recurrence kind of umbrella. We'll look into watch and wait. We'll look at the fear of cancer recurrence or progression, sometimes abbreviated FCR. And we'll also see examples in the literature, management and interventions, and kind of self-care versus coping, okay? So why are we even kind of concerned, right, about our population here? And, you know, studies do show that the cancer population is an especially kind of vulnerable one. There's quite a bit of psychological and psychosocial distress, right? So psychological kind of self-explanatory, mental, emotional stress, distress, that kind of thing. But we also want to highlight the psychosocial aspects of it. So is this a support system that's not exactly shored for you? Is it also things like finances, even things like housing and shelter and food, even insecurities? Is it things about your job situation, right? And sometimes being in this kind of cancer world can really put distress in both of these categories. There's also a higher incidence of comorbid psychiatric symptoms and disorders, right? And so these can affect your quality of life. It's actually been shown that it can affect adherence to treatment. So showing up to different follow-up appointments, taking medicines, being communicative about your side effects. Prognosis can affect caregivers, and it can also increase in at-risk behaviors. We all have ways of coping, and sometimes we'll pick up a way of coping that can actually have some risk to it or some harm to it. And so some common psychological themes, right, in cancer. And let me see if I can. Can you all see my whole screen? Okay. So a few of the themes that we see a lot. The first is the uncertainty. And it's interesting because I find that across the spectrum of different kind of cancers, uncertainty is one theme that really is quite prominent and pervasive. Now, of course, uncertainty, unpredictability, right, the unknown really kind of takes a forefront and can cause a lot of the distress that people go through every day. There's a psychologist here who I really admire, and she often says we have to make friends with uncertainty. And so she talks about what we can do to actually partner with it or to make friends with it, since it's something that is going to really be prominent through all stages of cancer care, from diagnosis and treatment to afterwards, to watch and wait, right? To kind of navigating and integrating the cancer experience into our lives. Body image and also body integrity is a big one. A lot of times people have learned to kind of trust and rely on their body, whether it is that, if they push it one way, it'll do this. If they don't push it this way, probably this will happen. And often a cancer diagnosis can come in and kind of be the thing making the most decisions, right, about our bodies in a certain kind of way, and the way that we see ourselves and the way that we kind of trust our physical body can sometimes call into question. There's identity and fragmentation. If you were always the person who was the caregiver in your family, and now your loved ones are taking care of you, right? It could be a big role identity switch or a reversal. Of course, there's a death and dying and mortality themes that come up for people to kind of be confronted in such a also kind of prominent way. Can cause a lot of different thoughts and emotions. Caregiver distress as well, right? We always want to recognize the loved ones who help to take care of us in the cancer world. And this thing called demoralization, right, which is not exactly depression, not exactly sadness, but it's kind of losing a confidence or a hope for some of the future. And it also it's a kind of seeing your purpose and your role kind of in your microcosm of your own world to change. And sometimes that can really be difficult. And so what are some of the common psychiatric disorders that we see? So I do see all of these in the cancer world here. We're going to take a deeper dive into the anxiety disorders, or I should say anxiety symptoms, just because I think that is a lot of the emotional impact, and especially about recurrence and watch and wait. But we see mood disorders, adjustment disorders, there's post-traumatic syndromes as well. We have cognitive side effects and syndromes as well. I highlighted one called delirium that sometimes people can get, especially post-transplant. So especially in the first few weeks after their transplant, or if you have really bad infection, right, something like that, sometimes people will get a temporary cognitive disorder called delirium. And then, of course, psychiatric emergencies as well. But just a deeper dive into anxiety. And so this is a pretty common kind of anxiety loop. And so there's a feared situation. And of course, that triggers anxious thoughts, right? Often that comes with physical symptoms, right? People usually know this as the fight or flight response. Sometimes people call it the sympathetic nervous system, the adrenaline system. But for many people, there's some physical sensations that are associated with anxiety. And it doesn't have to be a full-on panic attack, anxiety attack, right? For some people, they feel a difference, right? Some people have dry throat, sweating, there's butterflies in the stomach, right? Heart pounding, dizziness, shallow breathing. I always tend to ask the people I'm seeing is, are there little signs and symptoms in your body that sometimes give you a warning signal that maybe some anxiety is coming or spiraling might be coming? And it's interesting because a lot of people will say yes. I hear sometimes a heat, like a flushing in the back of the neck, hair standing on their arms, tension in their neck, right? Heart racing. And it doesn't have to escalate to kind of fainting and dizziness and stuff like that. But usually people do tend to have some kind of physical warning sign. And so then, of course, the physical symptoms then produce more thoughts, right? And thoughts, something's bad is happening, I feel awful. And then that might trigger more anxiety and more thoughts that say, oh, I really must be in danger, something horrible is happening. And actually that kind of does this loop. So a lot of interventions for anxiety is about how do I intervene in this loop, right? What parts of this what part of this loop can I affect some change in? If you guys have heard of cognitive behavioral therapy or CBT, that's one of the main tenets of that, right? So cognitive therapy says that thoughts, behaviors, and emotions are in a loop and they affect each other. It's interesting, for most people, it's either easier to intervene behaviorally or easier to intervene kind of cognitively. How do I reframe my thoughts? How do I look at this in a different kind of way? How do I kind of rationalize this? or behaviorally, right? What can I do right now with an action that might help to break the loop? And either one can get us to the emotions, right? Either one can get us to the anxiety and to help with that. And so having that kind of anxiety loop in mind, right? I did want to get like closer in on some of the things unique to the blood cancer population. So thinking about, putting the anxiety loop to the side just a little bit, right? But seeing what might some of the things that especially the blood cancer population might feel. So for right now, right, and this is 2020, 2021 data. So we can probably update it now. I can probably update it now with 22 data into 23. There's about 1.5 million people living in the US with blood cancers, remission from leukemia, lymphoma, myeloma, MDS, right, or the myeloproliferative neoplasms. There'll be approximately 9.8% of all new cancers diagnosed, right? So that's a huge percent. We're talking about a 10% group, right, in the cancer population in the US. And approximately one person every 3 minutes, right, gets a diagnosis of a blood cancer. So a lot of need, right? A lot of people who will be experiencing the words of getting a diagnosis and needing to undergo treatment and or the watch and wait or some kind of active surveillance, or I should say, and a lot of people who will have someone in their circle to experience it as well. So what is watch and wait, right? And so usually we talk about this with the blood cancer population with a closely monitoring, right, of different, usually lab results, sometimes imaging as well, right? But it's without giving cancer-directed treatment. And this, of course, has an asterisk to it, right? Is that until there are symptoms that appear change or become worrisome or debilitating. Often, these are the slower growing blood cancers, of course, or chronic forms. It can actually be a timeline of years, right? I know a lot of people in the audience are probably experiencing this now. And again, these are the things that are usually often monitored. And what's the definition of fear of recurrence, right? Or sometimes fear of progression, depending on where you are with diagnosis. And so the definition is really quite a straightforward one: fear, worry, or concern, right? Relating to the possibility that cancer will come back or progress. And so fear, worry, concern, for most people, that's on a spectrum, with fear being kind of the most severe and prominent, right? Worry being something that might pop up from time to time, but maybe not is so heavy, right? Not so twingy or spiking, something like that. Or concern. And I like this definition because it highlights that there's a spectrum of these kinds of emotions and thoughts, and also that one person can have all three of them, or one person can kind of live on one side of the spectrum or not. Now, of course, for all of the people that I see and hopefully in the audience here, we want to get this fear of recurrence or fear of progression to a place where, of course, it will still be present in some kind of way, but it won't be heavy. It won't be kind of a blanket that covers everything and kind of affects the way that you connect with others and do the things that you want to do on a daily basis. But that will be able to recede sometimes. Is it reasonable to think that it will ever go away? I have to say, I haven't met one person in the cancer world yet who says that they have no fear of this at all, or no concern, or no worry. However, I meet many, many people, or work with many people who sometimes over time, or through therapy or through kindness to themselves, right? It really does recede, right? It becomes something that we can live with, and that might have some flares here and there, but that is something that's not 24/7 and not heavy. So how many people report this, right? So one study here gave a really wide range, right? 30 to 70%. Now, I want to highlight, though, that with this 30 to 70%, it's moderate to high levels, right, of the fear. That other end of the perspective, the spectrum, the kind of concern and the worry, I think it would be something that, at least in my experience, just about 100% of people have. And I highlight that to say that it's normal, natural, common, and understandable. We talk about anxiety sometimes as something that needs to be kind of fully stamped out. But if everyone didn't have a little bit of anxiety, no one would go to work, take care of their families, take care of themselves. No one would say, oh, I need to go get a meal so that I can eat something, right? What anxiety is really is that you have a hope that whatever is in the future will work out well. And so it's very kind of normal thing. Now, of course, though, it's the persistent kind of severe part of that we do want to make sure doesn't hang around for too long, or that we can help you manage. And so what does it look like a lot, especially this this other kind of part of the spectrum? It looks like high levels of preoccupation. Often that's with your body. It's with research sometimes. Also with talking to doctors' offices a lot. There's a persistence of these kind of cognitions and emotions. What does that mean? It means that if people have some fear, some anxiety, some stress, some feelings of overwhelm, sometimes it's doubt, right? Sometimes it's anger. There seems to be a very kind of persistent, pervasive feeling of that. Cognitions is just the thoughts that you might have, right? That tomorrow I'm going to find out that there's a recurrence, or with each scan, it's never going to get better, things like that. And this kind of hypervigilance or increased paying attention to bodily symptoms, whether they kind of have to traditionally do with your cancer or not, actually. I want to highlight that it's across the disease continuum. So sometimes even for people who might have a genetic predisposition, so they know that it might be coming, even though they haven't been diagnosed yet, to people who have been diagnosed, to people who are in the watch and wait, to people who have started treatment, to people who are post-transplant. So this can really come up. Common worries in this situation, they can be disease specific, of course. The uncertainty, unknown, unpredictability is also a big kind of area for this. There's actually quite a few studies that really kind of quantify anxiety before starting treatment and after starting treatment. And once you have a bit of a window into what to expect, a lot of the anxiety decreases, even though there really isn't any change maybe about how you're feeling physically, or that you have side effects from treatment. But the only thing that's changed is that something that went from unknown is now known, and that can really reduce a lot of anxiety. Another common worry is loved ones, right? People who maybe you used to take care of, or you want to kind of reassure that you'll be okay, kind of no matter what happens. Or also, how can you engage them to be a good social support network for you? There are some risk factors for people who tend to have higher kind of levels and more severity with the fear of recurrence. Usually it's people who are more newly diagnosed, especially the first year after a cancer diagnosis. Often it's a younger age. Usually we talk about our AYA population, and that's for people who are diagnosed under the age of 40. They tend to have a bit more of this, even though we do see it across all ages and spectrum there. The people who are getting more side effects, more physical symptoms, who have had a history of some psychological distress, who do have coping, but like we said before, some coping unfortunately has some at-risk or risk, I should say, associated with it or harm. And also people who have had previous losses or traumas or in current caring roles. That last one is interesting because the caring roles do often give people kind of a sense of purpose and need and value. And most of the time, the caring role is for someone who people engage in some kind of connection or love with. But because the cancer diagnosis can really threaten a lot of that role, that's why often it's a risk factor for anxiety and this kind of fear of recurrence. And how often? So it really depends person to person, right? And this is also a kind of spectrum here. Situation specific, what do we mean by that? That maybe it's flared when you have a doctor's appointment. Maybe it's flared when they have a lab test for you, when they're looking at your blood counts. Is it flared when you get an image? Is it flared for your next biopsy? Is it flared actually if for some people, just walking by the cancer center will sometimes flare some of these anxieties. And then, of course, people have it kind of intermittently, so not associated with a certain kind of trigger or situation. Regularly, we usually say that's most days of the week, most weeks of the month, most hours of the day, and then this kind of constantly. That we see people who have all along the spectrum, but again, helping to manage, right, is to take down from the constantly and regularly more into these other areas. And when does it tend to be most prominent, right? We talked a little bit about this in the situation specific category there, but cancerversaries, right? I think people have heard about this term before. For some people, it's the date of diagnosis. Other people, it's the date of the first treatment. For some people, it's the end of treatment. It is different for each person. I would say for most people, though, it's usually around the date of diagnosis or biopsy. For some people, it is transplant as well. Also, follow-up appointments. I did want to highlight kind of public health campaigns and social media. I think, we're in a world where so much is accessible now, including about very prominent people in our lives, political, celebrity, different kind of well-known authors and actors, actresses. And so sometimes it can feel, it's hard to avoid hearing about some of these things. And a lot of people do say that some of the anxieties will get flared with that. New diagnosis of loved ones. And so we saw in the previous slide, right, how prominent the blood cancers are, and whether it's someone who has a diagnosis of blood cancer or a different kind of diagnosis, it is something that a lot of people now are in very close proximity to. And so sometimes a new diagnosis of cancer in a loved one can also flare our own fears of recurrence or progression, even when, all the kind of evidence points to that we're doing quite well. And then, of course, physical symptoms and aging milestones, right? And so sometimes that aging milestone is as kind of straightforward as a birthday, but sometimes it's also for a lot of women, for example, when they hit menopause, sometimes that happens. And sometimes that's based on hormonal changes, so more of a biochemical basis. But also it's kind of like, what does it represent usually kind of like psychologically, at least in our Western society. So those kinds of things can also make some of the anxieties and fear of recurrence a bit more prominent. So what does it look like? What might you feel, right? We talked a lot about anxiety, but sometimes it could also come in the form of irritability or sadness, right? And this is just a few different things. I highlight irritability because quite often I'll see someone, whether it's here in my clinic or in the hospital, and they say, I'm fine, right? I'm not depressed. I'm not anxious. I'm not scared. I'm not happy, but I do feel like my patience is short. And the things that I've always been able to kind of ride with are now bothering me more. Sometimes they'll use the word irritability, but I hear things like I get pissed off more, I have decreased patience, things like that. So sometimes this can be a sign of this. Sadness is a bit more straightforward. I think people can see how sometimes there might be feelings of sadness associated with these kinds of thoughts or fears. And so what might it look like for you or for your loved one who might be dealing with the emotional impact, right, of fear of recurrence or this watch and wait kind of time? And so in two of these kinds of buckets here, one is reassurance seeking behavior. And so often this looks like people wanting extra visits with their doctors, right? Often it's with the oncologist, right? The cancer doctor themselves, but sometimes it's with other doctors as well. Kind of like healthcare clinicians, but often it's with the oncologist. Over treatment, what do I mean by that? And I'll look in the chat just after I finish this group. I'll look in the chat to see what that comment is. Over treatment means maybe you are experiencing some side effects, and we always want you to use the least amount of medicine that will be effective. But there's a fear of either having more of the physical symptoms or a fear of actually them coming back on. So sometimes people will take more medicine of actually the supplemental medicine supposed to help side effects. There's also sometimes people who seek out different doctors' opinions and kind of also ask for different treatments depending on who they're seeing. Sometimes it also looks like people excessively kind of examining their bodies, right? So I checked my, clavicle for the lymph nodes yesterday or this morning at 2 o'clock, but I'm going to check it again at 6 o'clock, and I'm going to check it again before I go to sleep at night. And then interesting, right, is that there's this kind of opposite behavior we hear a lot that's more like avoidance. And so people might skip or delay follow-up visits, right? They might use substances or another kind of coping, right, that has risk or harms, but they take them away from the fear. It's a big kind of distraction. And distraction, that's a bad rap, but the brain needs some distraction, right? Always. The brain can't be kind of on fire and angsty all the time. And so, some distraction is very good. But when it looks like there's a use, especially of a substance or something that you're ingesting or something that you're doing that is taking you away, right, from all of these fears or anxieties, then it can really go into a problem. And then this last one, sedentary, excuse me, and isolation behavior. Sometimes people will tell me, I used to love having coffee with my next door neighbor, and now I'm avoiding their texts and their phone calls. I'm just on my couch, kind of scrolling through social media, scrolling through the channels, or sometimes not even doing either, just sitting and staring, things like that. And that can sometimes be an avoidance as well. Let me just see what the chat is saying. Oh, okay. Yeah. Thank you, Liz. Thanks for letting us know. And I do want to highlight this sometimes because they're very different kinds, very different behaviors, right? Very different ways that someone might look, either kind of over asking for reassurance or actually pulling away. But both can be signs of the same thing. Okay. And so why are we even concerned, worried a little bit, right? That some people might have a heavy kind of emotional impact right now. That there are these potential consequences, right? To, again, the brain doesn't really like being always in this kind of angsty, anxiety-ridden state, even though, sometimes, right, we all need a little bit of it. And so, studies have shown that it can lower quality of life. There are some, let's say, groups of things we look at a lot for quality of life, right? Connection to people, kind of enjoyment, satisfaction with life, purpose, value, this kind of thing, comfortability. But I also put this here to highlight that quality of life really is so unique, also person to person. So even though you might have food and shelter and clothing and access to care and stuff like that, you might find that a lot of the things that kind of brought you some joie de vivre, like a kind of a joy of life, have gone down. Or you might find that connecting with others just doesn't feel exactly the same. And so sometimes that can also be a kind of signal or a harbinger for some of these things here. Another potential consequence that we talked about, especially for people who are in that group of people that have high reassurance-seeking behaviors, is greater utilization of healthcare services, right, including tests and scans and costs, right, excessive medical reassurance-seeking. And increased healthcare costs. And we will also put in their travel expenses and missed work opportunities if you are still working. And so a lot of kind of like financial costs as well as time costs as well. Energy costs too, actually. And then, of course, the emotional and psychological distress. I also wanted to highlight some of these things. Concentration difficulties. Now, this is something that unfortunately a lot of people in the cancer world who might not be experiencing these kinds of fears will have from treatments often or from fatigue often. A lot of times concentration and attention actually has to do with low energy more than anything else. But sometimes it can also be a part of this fear constellation. Sleep disturbances, and this is both people who have trouble falling asleep, have trouble staying asleep, and then have something called early morning awakening. So it can be in the beginning, the middle, or the end of sleep that you might find that is a bit more challenging to do, or sleep might not be as restful as it could be. Panic symptoms, we kind of talked about that the physical, a lot of the physical symptoms associated with anxiety. And of course, all of these things can affect our well-being. And so in particular, with your relationship with kind of oncology and the watch and wait appointments and so forth, right? There might be a greater utilization of preventive healthcare measures, right? And so I think we all are kind of used to being on social media and saying, do this, cancer will never come back. Don't do that, cancer will never come back. And so sometimes people will get, very into following these things kind of to the T. Also engaging in actually beneficial health related behaviors, right? So I also wanted to highlight that while some of the consequences can be, maybe not the most beneficial, sometimes it can help, right? So having a bit of a fear of recurrence or a bit of a fear of progression can actually help us to adhere sometimes to treatment plans and adhere to some of these um, kind of lifestyle choices that are really quite helpful in the cancer world. So how do we navigate all of this? I wanted to highlight some kind of patient quotes, right? So if it comes back, I had sort of the first 5 or 6 steps I was going to do and sort of how to manage, and I had planned a little bit in my head, right? And so there are some people who really do say, well, if this happens, then happens, right? So there's that kind of person. Then there's a person who says, I can sit here and worry for 3 months, or I'll worry a lot the day before. So I'm going to choose to worry about it the day before. I don't think about it until then, but I put it in the back of my head. And that's my strategy for dealing with worry about the results of a test or, the results of something, a biopsy or something a bit more invasive. Then there's people who say, I yell a lot, right? I need to scream. I need to have an outlet. I need to have some kind of dispense, right, of all of this angst and anxiety. And so whoever you are, right, in this kind of spectrum, an organizing worrier, a delayed worrier, or maybe a more kind of outlet kind of worrier, right? It can take on a lot of different forms. But the important thing here is that all of these 3 people are doing an outlet, right? They're having a behavior or a way of dealing with their thoughts that is helping them cope. And so, again, living with uncertainty is never easy, right? But we can manage. I did want to just talk a bit about caregivers, and some have the same kind of themes, right? But just I always want to highlight, right? They need their own support, right? Helpful also to get from medical teams. Of course, the person going through the cancer diagnosis and treatment and watch and wait and so forth. Usually we're in some kind of relationship with whether romantic, familial, platonic or otherwise. But it is really helpful for caregivers to get their own support, right? Whether it's from the oncology medical teams themselves or their own doctors. But contact, right, it continues to be extremely helpful. Caregiver distress is real. It can be overwhelming. It can also affect the way that the caregiver, right, that the loved one actually has some confidence in how the person is going through. Through treatment and their own kind of cancer world. So it's an important thing for us to kind of highlight and to remember. Okay, so what can we do, right? How can we navigate this world? So, of course, there are some clinical interventions, right? I wouldn't be a psychiatrist if I didn't talk about these things. And so the hope is that in all kind of oncology clinics and appointments across this kind of vast country and hopefully internationally too, some of these things will be kind of normalized, right? It's very common for you to go to your oncologist's office and you might do something called a distress thermometer or a distress scale. So that's part of the screening here. Sometimes they'll do a more extensive scale looking for depression and anxiety symptoms. Sometimes they'll also ask about self-harm behaviors. And there's been a big push from the National Cancer Centers to really normalize a lot of this screening. And then, of course, psychoeducation. So hopefully part of the oncology visits is about, what we can do with this kind of, if we are having this kind of distress. Now, in this age, especially in the kind of after COVID parents' world, online and virtual, right, including us here tonight, has really increased accessibility for a lot of people. Of course, there's still the good old telephone as well as face-to-face and in person. There are things that you can do individually or with groups. There are a lot of different groups I know through the Leukemia and Lymphoma Society as well, and Red Door, right? And so, you know, people have different uh, experiences with groups, but I always encourage people to try. Of course, there's inpatient and outpatient settings. There's research trials for emotional impact, right? For more of the psychological and psychiatric distress. So that research trial there is in oncology, but for emotional impact. I wanted to highlight a little bit addressing the existential issues. I think for a lot of people who have this kind of diagnosis and navigating this cancer world, a lot of it is about the whys or the questions that may never be answered. Some people say, why me? Other people say, why not me? Sometimes it affects kind of the way that people have always kind of moved through the world and their kind of narrative for how moving through the world kind of exists for them. And then, of course, to highlight some of the psychotherapy, right, that cognitive behavioral model that we talked about. And so what can help, not so formally clinically, right, seeing Dr. James in her office here at MSK or anywhere else. So learning about the diagnosis. So research does show that a small amount of research, or let's say an appropriate amount for person to person, really helps. So not knowing anything about the kind of blood cancer you have, what rot and weight really means, actually can increase fear. But knowing some of the basics, knowing some of how it appears, especially in your body, so very like person-centered knowledge can be helpful. I put in some practical things, right, like maintaining health insurance coverage, right? We're in a country where that is necessary. And so doing what we can to do that, keeping up with appointments can help. And staying informed of kind of like future treatment plans can also help. What can help kind of on a larger scale for well-being, right? We hear a lot about diet and exercise and sleep and rest time and all of these things. And so, of course, I'd be remiss if I didn't say something like that. But I also wanted to talk a bit about this, right? This is what helps too. Talking about it, recognizing it, acknowledge it, and not ignoring it, right? So I think us in the cancer world here really want to impress, right, upon us. That number was 30 to 70% for moderate to severe fear of recurrence. And if we're talking about mild to moderate, right, probably the numbers are approaching more like everyone. And so it's helpful to kind of normalize this, to say this is common, this is typical, it's understandable. But with that, right, and in the same breath, we also have to say that it can't be something that's so heavy that takes us away from the different aspects of the quality of our life. So talking about it and recognizing is really just the first step, right? Getting support from these kind of groups, right? Loved ones groups, counselors, journaling helps it to make it less overwhelming, right? Also getting suggestions from others and what has helped, right? That's what I love about some of the groups, especially with our two organizations here. That could really be quite helpful. Changing your focus, of course, right? Distraction, shift attention, hobbies, take a walk, humor, and then some more of the therapies, meditation techniques, relaxation techniques, right? As well as the psychotherapy. So I did want to highlight it in our last kind of a couple slides here, and then we'll have some time for open questions soon, is when we talk about self-care versus coping, how are they different, right? So I like this. It's from Talkspace, and it's a really good reminder, right? Self-care has like a big buzzword now, and it's lovely, but I do think sometimes people are either overusing it or maybe not thinking about the function of it a lot, right? So self-care is a preventive measure. Self-care is not the thing that you do to respond to anxiety and depression and sadness and fear and anger, right? Self-care things, the way that to think about it is this is what helps prevent some of these anxieties and helps prevent some of these big spikes and big kind of valleys that people tend to get through. And so they are acts that attend to all of these things: emotional, mental, spiritual, physical health, right? They can decrease extreme distress and even burnout, and also can decrease the need for coping in the future. So again, it's a preventive measure, very different, right? Each person. And sometimes it's good to have different things to do in these different buckets: emotional, mental, spiritual, physical health. Coping, on the other hand, it's what you use as your toolkit to get you through tough times. So when the stress is there, when the overwhelm is there, when the existential questions are really getting too heavy, now you go to the coping. And so they can be activities, they could be strategies. It says tactics here, right? When you also need to buy a bit more energy or time, right? Hitting the pause button. These can be different kinds of things that you use for coping. And so sometimes when people say, well, that's great, but how do I, where do I start, right? One way to divide it up is what can you do if you have a minute, an hour, a day, or a week? And especially in the cancer world, right, we highlight this minute or hour a lot, right? What can you do if you're in the waiting room? What can you do if you're in the hospital? What can you do if you're actually transporting yourself to a different kind of appointment or follow-up? What can you do that doesn't take a lot of coordination or navigation, right? And, a minute can, obviously be a little bit more, maybe a minute to 5 minutes, right? An hour or two, right? A day or two, and a week. Often people don't have a week to do a lot of these things, but when the time does arise, or we can step away from kind of like our daily routines, either go on vacation or maybe see loved ones, or just make a change of scenery. What does that feel like for you? And so sometimes it's helpful both to have self-care things as well as coping things. And not saying that the both can't overlap, of course, but in these kinds of buckets here. Sometimes I also talk about, instead of minute, hour, day, week here, what can be done kind of by myself or with other people, or by myself, or that I have to do something, right? If I like music, then I have to buy a ticket to go to a concert, or I can have a playlist ready on my phone or ready on my iPad with a playlist for when I'm feeling sad, a playlist for when I need to pump up, a playlist for when I need to be kind of inspired. So what can I also do without kind of finances or coordination, buying a ticket, figuring out the day that I can go, and what can I do with just myself? And so, we talked about the anxiety loop, and some features of anxiety that is a bit more specific to the watch and wait community, or the fear of recurrence community. But I think as a psychiatrist, I'd be remiss if I didn't put in some of these other kind of anxiety symptoms that people often hear and see. Sometimes it comes as overthinking, right? We talked about avoidance, and needing reassurance, the lack of patience, right? So it's a lot of different things here. But it's good sometimes to see which ones of these are your thing, right? I do work a lot with my people about how to recognize these kinds of things and what to do. Okay. And then the last bit here is about kind of red flags, right? And so these are the things that are really quite worrisome, right? Severe isolation, severe changes in appetite and diet, right? Thoughts of self-harm, both thoughts of actually killing yourself or ending your life, but also about things, what can I do to hurt myself right now? Overuse of different kinds of coping substances, even things like exercise and research is kind of good, quote unquote, positive coping, if used excessively, can also have its own harm. And then impulsive behaviors, sometimes people tell me it's not like me to do X, Y, and Z, right? So these kinds of things, if these kinds of things are coming, right, or appearing more often, we do really say try to seek out a kind of more formal mental health care. Okay. And so right? Be kind to yourself and with yourself, right? Staying present, living in the now, important things to consider, especially in this cancer world. Sometimes I say it's not even one day at a time, excuse me. Sometimes it's an hour at a time, right? And living in the now is a really good kind of reminder for that. It's also really important to reflect on what makes your life meaningful, right? And this is both before and after cancer diagnosis, and to honor these kinds of values and activities that are important to you, almost like a guidepost or a compass for you. And so those are the kind of take home points, right? We talked about cancer as the cancer population is a kind of vulnerable group, right? With these psychological themes, a variety of interventions to remember our caregivers and watch for red flags. But I think a big part of it is being kind to yourself about these very kind of normal thoughts and emotions that may come up. Okay. That's kind of the end of my slides here. I'll stop sharing and see if there are questions.